for
16-year-old girl.
yes, ma'am. 16-year-old female girl from Haldwani and
Mm.
class 9 student.
Mhm.
History was given by her brother, and
Mhm.
her present complaints were progressively increasing shortness of breath and
Mhm.
bilateral lower limb edema for last of 15 to 20 days.
Mhm.
The history dates back to September 2022, when she first developed facial puffiness, which was more prominent in the morning, and this was followed by bilateral lower limb edema till ankle. And this edema, as well as facial puffiness, had developed over 15 to 20 days back then. This was associated with low-grade fever for the initial 2 to 3 days, without any chills or rigors or any burning micturition or any cough. And that fever had subsided after taking some over-the-counter medications for fever. Uh, the patient also told that she had pain and stiffness of joints for initially first few days, which had subsided spontaneously. She could not specify which of the particular joints, and what she had told that this was a bit of a generalized sort of pain. But there was again no joint swelling or any deformity, and that pain as well as morning stiffness had subsided spontaneously. There was no history of any rash or ulcerations, mouth ulceration, any shortness of breath, any hair loss, any alternative medicine intake, any seizure, any visual disturbances, any difficulty in swallowing, or any opening of mouth back then. There was no history of any hematuria or any decreased urine output. And with these complaints of bilateral lower limb edema, she had visited a local physician who had evaluated her, and she underwent a few laboratory investigations, and she was told that she was in her urine there was leakage of protein as well as blood, and she was also told that her serum creatinine level was around 2. Moreover, she was told that her blood had high cholesterol levels, and she had some deranged thyroid tests. After this, she was started on tablet Lasix, she could specify, and back then her blood pressure was normal. In view of deranged kidney function test and proteinuria and hematuria, she was referred to a nephrologist in the month of September 2022. And under the care of the particular nephrologist, she had underwent a biopsy, which was uneventful. The biopsy report had come in a couple of, in 7 to 10 days of time, and after which she was started on oral steroids. The dose that her brother could specify was 60 milligram, and they told that this was gradually tapered off. And there were some few other medications which they could not specify. Uh, Over the period of next few months, the patient kept on following up. Her symptoms had subsided to an extent, and she was told that her leakage of protein as well as creatinine were getting better, but we don't have any documents of that time. But after the month of February and till June 2023, she had lost for follow-up, and during this time, she had totally stopped taking all the medications as well. So during this period, her lower limb swelling had again reappeared, for which she herself took a few Lasix tablet as well. And then, as time progressed, her breathing difficulty had increased, and lower limb edema also increased, which led her to present to us. Uh, and after, so once she presented to us, she was evaluated again, and then she was treated in the line of the disease process.
On the line of?
On the line of, sir, kidney, I mean kidney involvement, kidney, that will, shall I tell you, course in the hospital.
Okay, so now comes the course in hospital. So let me go here. Okay. Okay, complete the history first.
Yes, ma'am.
Yeah, include the hospital course also if you want.
Ma'am, on
That's also part of history, right?
yes, ma'am.
Okay,
On her
may as well
presentation,
complete.
yes, ma'am. On presentation, she was found to be tachypneic, and her blood pressure was on the higher side, and she had edema. And in view of this, she was started on diuretic infusion and other supportive measures. and then she was further evaluated, and all her histories were looked into. And she was initially admitted for a couple of days, and then we had started her on certain medications, and after that we had kept her on a weekly follow-up. After 3 weeks, again, patient showed some deterioration in the laboratory features, I mean the laboratory parameters, and then the patient was again advised for hospitalization, but the patient and the family refused, and they again they were lost for follow-up, and they went to some other hospital.
Okay. All right.
Um, so personal history, appetite was reduced, and bowel bladder
You
habits were.
have anything in these 2 days in terms of hospital course? You haven't told me anything, except that the admission was for 2 days.
She was evaluated, and we
Okay.
got the
You are
reports.
not privy to evaluation. Is that correct?
I'm sorry.
You do not know the evaluation.
I know, ma'am. I have the reports and
Okay.
everything. Like
All
I
right,
can.
chalo.
Okay.
Okay. Were
So
you
in
following her during this period or you were not? Were
yes,
you
ma'am.
involved in her care?
Yes, ma'am.
Okay. All right.
So, ma'am, in further history, personal history, only appetite was reduced, bowel and blood habits were okay, normal. Sleep was a little disturbed. No addiction history. Menstrual history, she had attained menarche at 12 years of age. Her cycles and volume were normal. But now, when she presented to us, she was amenorrheic for the past 6 months.
Okay.
And family history, she was the second child born out of a non-consanguineous marriage, but there is no significant family history relating to the current symptoms or any history to any other systemic disorder, including any kidney disorder in the family.
Okay.
Vaccination history, they could not specify any particular vaccination other than the COVID vaccination that was taken. This this is the
This is
history.
all in the history.
Right.
Okay. So, you want to make a diagnosis, although you were involved in her care. So let's presume you had not seen her before the admission
All
or
right.
at admission. What did you think about the diagnosis at that time? At the time of admission, since you were now involved in the care. Okay. So she comes with some, let's say, 6 month history, 6 to 8 months history of something, something. All right. So what was your initial impression?
From the history that they had given us, uh,
Mm-hmm.
with the history of having raised serum creatinine and passage of blood and protein, as well as the primary complaint has been uh, this one swelling and anasarca sort of feature.
Mm-hmm.
So, what I thought initially, this was a case of nephrotic syndrome per se.
Okay. Nephrotic syndrome is one. Okay. Any
There was no
etiologies you want to attribute? Okay. Second, syndromic.
second syndromic could be chronic kidney disease because the history has already been almost 10 months or so.
Yeah.
So these two I had kept.
Okay. Chronic kidney disease. Okay. Any clue to etiologies you would like to give here at the time of admission?
Uh, Being a female, young female from reproductive age group and all, and she had given a little bit of history of some joint pain very in the very beginning of the disease process. So the first thought that came to my mind was probably this was a case that we're dealing with was lupus nephritis.
Okay. Anything else?
Then again, age being younger side, I thought IgA nephropathy would be another differential
Okay.
diagnosis.
For nephrotic syndrome?
Ma'am, I would keep it a bit on the down the line, but
No,
I would,
after SLE agreed.
yes, ma'am.
Okay.
And
For okay. CKD, any guesses?
CKD, ma'am, could have been again lupus nephritis or FSGS that has progressed.
CKD, FSGS. Okay.
And one more diagnosis on the nephrotic syndrome side would be MPGN. with that also, because she had some
Okay,
fever.
that's a very broad group now. It's practically a pathological diagnosis now. So I think it may be better to call it a glomerular disease. And maybe you could delve into secondary versus primary, or a systemic versus a pure kidney disease, isn't it?
This one.
So in terms of, okay, SLE and a pure kidney disease would be
IG.
in your second case FSGS. All right. But didn't you have, at the time of admission, you had a biopsy?
Ma'am, I just missed you. There was some
Ankur.
connection.
Yeah, I'll say it again.
Yes, ma'am.
So at the time of admission, you had a biopsy report which she had,
Yes, ma'am. The
isn't it?
Yes, ma'am. The differential that I told you, this was
What happened to the biopsy report?
the biopsy was clear cut,
No,
ma'am.
no,
So
no. I'm sure the biopsy is clear cut,
yes,
right? So I want you to look at the time of admission. The history included this biopsy report from outside, didn't it?
yes, definitely.
Which that's why I asked you in the beginning. Were you involved in the care? If you were in, so you had a biopsy report. You want to tell me the biopsy report, because it's better to take this case from there.
Yes, ma'am. Biopsy report I can watch.
Okay. So at the time of admission, you had the biopsy report. And let's see what that biopsy report was.
Ma'am, the biopsy had light microscopy and immunofluorescence. There was no.
Okay. LM and IF.
LM had 24 glomes, ma'am.
Okay.
Them were globally sclerosed. They had diffusely
Say
marked.
that again.
None of them were
Okay.
diffused
No
globally
sclerosis.
and
Right.
diffusely marked mesangial hypercellularity and
Okay.
mesangial matrix, and all glomes had revealed segmental global endocapillary cell proliferation.
Okay. All gloms had segmental endocapillary proliferation. That's what you said?
Yes, ma'am. With the variable intracapillary and mesangial neutrophil infiltration.
Okay. So there is acute infiltrate. Okay.
Yes. 10 gloms
Neutrophils.
had, yes, ma'am. 10 gloms had cellular crescents.
Okay. 10 had cellular crescents.
And 2 revealed segmental fibrinoid tuft necrosis.
Okay. So some had tuft necrosis.
10% IFTA.
Okay. 10% IFTA.
Few RBC casts.
Okay.
IF, ma'am, had IgA 2 plus, IgG 3 plus,
Okay.
IgM 1 plus, C3 2 plus, C1Q 2 plus. So it was a
Okay. Full house.
Yes.
Okay. So the diagnosis was clear to you at the presentation,
Presentation.
because this girl had a biopsy with you. Okay. Now, what we need to understand now is, did you probe her for any previous history prior to September? So it's rather unlikely in the course of SLE that she gets a sickness for, let's say, 15 days, which is so advanced. I'm sure she had something even prior to September. When was this biopsy done exactly?
This was in September.
Okay, September. So at the outset, somebody has done a biopsy, which is a very good thing, right? Okay, so did you now, in view of this biopsy, which shows advanced, fairly, it's easily classified as diffuse SLE and has gone back, and have you tried to get some subtle symptoms that she may have had maybe 4 months prior to September, 5 months prior to September? I'm sure she must have had something.
When we did ask all the symptoms that we probably associated with SLE, like if she had anemia, she would be lethargic. If she had any loss of hair, any mouth ulceration, any edema, or any increased this one nocturia and anything. But very surprisingly, they were unable to give. So it was indeed surprising, but it appeared to be that this was on the onset was in
Yeah,
September.
it can't be. It's not sudden onset of disease anyway. Okay. So let's take it from there. With this biopsy, how would you choose to treat her in September?
This
Or how would you have chosen to treat her in September? Oh, no, okay, she came to you, but let's say, let's go back to September. If you were the nephrologist involved there, what else would you do? How else would you investigate her at that point? The
I would,
biopsy.
sorry.
Hmm.
Ma'am, regarding the usual common blood investigation, we would have done CBC, RFT, urine RM, 24 hours urine protein or UPCR. And as the biopsy was done, so I guess the ultrasound was done, which was required. We would have done a ANA as well as ANA blood profile. Uh,
ANA
the
what profile?
ANA profile, the ones
What
that,
is ANA profiling?
the one that shows all the other different
ENA.
antibodies. Yeah,
ENA. So
DSDNA,
how
SLA.
does ENA help over ANA now?
Ma'am, ANA can be present, and but it is not specific. It is one of the entry criteria for SLE, but it is not specific to SLE. Some
Okay, it
other,
is not specific. What kind of sensitivity does it have? Or let's say we all combined here get our ANAs done. How many of us would turn out to be ANA positive?
I don't know the exact.
Okay. Okay. Why? Why has the current criteria fixed the titer at 1 in 80? So the current the entry criteria is 1 in 80, right? Right. And this wasn't an entry criteria in the previous classification or the classification. Okay, this was not an entry criteria. So it must be based on something. Now they have fixed a titer also. Anyone wants to contribute to this? Any of the other participants? So let's say we pick up some normal people or somebody with joint pains, blah, blah, blah. How many of us will have, in a way, my question is false positive ANA? Because this happens very often that you send it for some disease, some fever, and it comes out as positive. Okay, common happening in your hospital also, Ankur?
Sometimes we do see.
In my hospital, it's a very common occurrence that physicians send it for some disease, some fever of 5 days. It turns out to be positive. They start chasing lupus, and it is not lupus. So roughly with lower, at least it was approximately 30% positivity. Okay. And once they increased the titer to 1 in 80, the false positive came down to something like 5-10%. Right. So that's why they have fixed the titer at 1 in 80 as an entry criteria in the current classification or the diagnostic criteria, whatever you may call it. Okay, that's how they arrived at a figure of 1 in 80 because the percentage of false positives comes down from 30-35 to 5-10% now. Okay, so what's the method used?
Immunofluorescence.
Immunofluorescence. Okay. Do you order ELISA also or just immunofluorescence?
ELISA, in clinical practice, we do send ELISA sometimes. That gives us the report earlier. But immunofluorescence is a better and more specific
Okay,
method.
good. So this is supposed to be more specific, and that's the one advised in most classifications of SLE. Okay, so that's ANA. Now, what will whole ENA profile, ENA, add to this information now?
In ENA, we look at the
Or you
specific.
would order, or you would like to order some. Look, the clinical suspicion of SLE was there at the outset.
That's right.
Correct, September 22. So would you, ENA, if I'm not mistaken, costs something like 15 to 20,000. Am I correct? Right. Would you order a specific antibody or order the whole gamut of ENA? It contains some 10, 11
So, ma'am,
nuclear antigens.
if I mean if I have to look at one, I would look at DSDN and anti-Smith. But since
Okay.
this was a young girl and very rapid, I mean sudden onset, So it would be more pertinent to send the whole profile, because we don't know if there is any history of any drug intake or not. And she was again in the
No, that
reproductive.
can be asked. She's an educated girl,
Yes, ma'am.
probably had an educated brother.
She initiated.
Why would a 16-year-old take drugs? And which drugs cause lupus anyway?
Hydralazine and
So somebody would take hydralazine for high blood pressure. Why else would one take it? I see no reason to take hydralazine,
no
right?
history. Yeah, in history there is no like
Right.
particular.
So it's easily elicitable. Which other drug causes it?
Um, uh, uh, minocycline, any other sulfasalazine drugs,
Yeah. So that's also for, to my knowledge, ulcerative colitis. So one
colitis.
has to have a disease, otherwise, who would go and take sulfasalazine? Right? So look, healthcare has to involve some economics also. I see no reason to order these inner profiles. Just order specific things. Okay, so what specific thing? Anti-dsDNA and
Smith.
anti-Smith antibody. What's the significance of anti-Smith antibodies?
Anti-Smith antibody is even more specific than dsDNA, but it is
Okay.
less sensitive.
All
So
right. So you order both, or I normally order anti-dsDNA alone. All right. So what was anti-dsDNA in this girl?
it was positive. It was around 6 times more than the upper limit.
All right. Okay. So do the titers of anti-dsDNA relate to clinical activity?
Yes, ma'am. It higher the titer is, it shows that the current disease.
Usually it would, and it would satisfy your need if you ordered just one and spend 1,500 instead of
The whole.
15,000. Okay, anything else?
Ma'am, C3, the complements, the C3 and
All right,
C4,
you will order compliments. And what was the result in this girl?
both of them were low, ma'am. C3 as well
So
as C4.
both of them were low. So now, so having said all this, do you have any other diagnosis now besides SLD?
Mm, not, ma'am, no, ma'am. If we are
You should
having
have
that,
the courage to say no.
no, ma'am, nothing. I would say
Okay,
nothing.
so you should have the courage to say no. That's what I'm trying to arrive at. So be confident. Say with these things, there's no other diagnosis.
Right.
It is SLD. All right. So now, when you investigate this girl, what else will you look for?
Ma'am,
Did any extrarenal manifestations?
ma'am,
You said arthralgia.
yes, ma'am.
Anything else?
From I mean, a laboratory point of view, we'd like to see, ma'am, a complete blood count as well. Whether she had any.
Okay. So
Yeah,
tell me the numbers, complete blood count at admission.
her hemoglobin was 8.2,
Mm-hmm.
and the total count was 4,500, and platelet was
Okay.
not. Platelet was around 1 lakh.
Platelet was normal. So 8.2, she definitely is anemic. So do you want to think anything beyond this 8.2, or you are leaving it there?
Ma'am,
It's not normal to have a hemoglobin of 8, right?
right, ma'am.
So what do you think about it? Did you look for it? What kind of anemia is this? Or
Ma'am,
what kind of anemia can happen with lupus?
the CBC of this girl had shown a hyperchromic microcytic anemia.
All right.
But I would have probably done a iron estimation.
Okay, you would have done iron estimation. Anything else?
Uh, mm, I mean, laboratory wise, I would have done that only, ma'am. I don't see any requirement of uh, young. No, ma'am, this much only. I would not go for any hemoglobin electrophoresis that at this point of time, or any B12 or folate estimation. And from
Okay.
history also, there's no history of menorrhagia and all.
So you think B12 and what electrophoresis?
From and folic acid. I'd
So
like to.
electrophoresis is really out of the blue here. I'm not talking. So what's what kind of anemia can happen in lupus? That's what I'm trying to ask you.
Normocytic, normochromic.
Normocytic, normochromic. So what's that anemia of chronic inflammation?
Chronic.
Is it this severe? Usually no.
Usually not.
Okay. Then what else?
I have to
Look,
take a look.
SLE is a multi-system disorder. You need to think beyond your your colleagues are answering. So Anish, Dheeraj, they have already answered what should be done. So look for autoimmune hemolytic anemia, which is part and parcel of SLE very often, right? What test would you do for it?
Peripheral smear and
What will you find in peripheral smear?
there might be cystocytes, ma'am. There might be
Okay,
fragmented
you found a
RBCs.
few cystocytes.
Fragmented RBCs.
All
We'd
right.
also try to look at serum LDH level. If there is hemolysis, then
Okay,
that.
so you look at LDH. What else?
Uh,
Something which tells you this is, look, LDH doesn't tell you it's immune or non-immune. Cystocytes don't tell you this is immune or non-immune. Let's say this girl was getting TMA added to it. Okay. You'll have to distinguish whether she has TMA or autoimmune, right? By your current test, it could be anything.
Cum test will be helpful in this one.
All right. So you will do Coombs test. Okay. So you will do a DCT. If it's positive, it supports autoimmune. Let's say it's the other way. It's a non-immune anemia, non-immune hemolytic anemia in a lupus patient. What does it tell you? Let's say she has a high LDH, she has cystocytes, and in biopsy also you found some TMA. Where does that take you?
TMA can be a part of lupus.
Okay, but so do you investigate it further or you just leave it that it's a part of lupus?
We'll have to take a look at ADAM-TS.
Okay, so that's one. That a combined TTP.
Yes, ma'am.
What else?
Have to rule out any concomitant infection with cultures and.
What infection are you talking about? I don't know.
Might cause atypical HUS if she had any.
Okay, then you talk about HUS then. So a complement mediated. So TTP is ADAM-TS deficiency, a complement mediated TMA.
Yes.
Right? And the third thing, which is typically SLE, APLA syndrome. That also manifests with TMA. You may find systemic things, you may find it on biopsy. So you need to look at APLAs.
Yes, ma'am.
All right. So those would be the three things you kind of take from anemia. So just don't leave anemia part of lupus. That I agree, we often do, but as a postgraduate, you must think a little wider. Okay, and get to the root of the problem. All right, so you found no leukopenia, normal thrombocytopenia. Next, what else did you do on admission when you knew the diagnosis is SLE? I'm not even going into differential because in a clear-cut SLE, there isn't much differential, right? So what else will you look for?
Had a chest X-ray done, and all the viral markers were done.
Normal chest X-ray. Go further.
Urine routine was done.
I'm sure it was. So what did the urine routine reveal?
The
Did
one
you
that
do this yourself? Urine routine?
I remember she was not done. So
No. So the time she was admitted, you didn't do this urine routine yourself, or at least go and see it. No?
No, I did that.
Okay. How many times have you seen in your, what you are, a second year, third year?
No, I'm in second year.
You are in second year. So how many times in your tenure of 2 years you have seen, let's say, any casts or any urine routine?
A cast I've seen only once. To be honest, I would see only 3 or 4 urine samples till now.
Okay, so this was one golden opportunity, right?
Yes.
which you have missed. You could have gone and seen the red cell casts in this girl's urine. She came with a diagnosis. Now you have to increase your other skills, right? She came with a diagnosis. You didn't have to put any energy into diagnosing her. Hone your other skills then, right? Okay. So you could have done that, which you didn't. All right, go further.
Mutation झाल्यामुळं.
Rahul, you want to say something? Okay. Go further, Ankur. What else did you look for?
Ma'am, this much investigation was, ma'am, enough.
This is all that was done.
This was
So,
done.
according to me, any girl who comes with lupus, you should look at extrarenal stuff. All right. So there are a few things that you can do at least, like a chest X-ray, ultrasound. I'm assuming you did it. Look at spleen. Look at liver functions at least. A lot of patients will have transaminitis, so that should be in your head that it can cause hepatitis, it can cause pleuritis, it can cause interstitial pneumonia. Right?
LFT was done. Only there was only hypoalbuminemia.
Okay, but again, you have to look at it. When you have to give the patient a comprehensive treatment, right?
Yes.
All right. So here is a diagnosed girl with SLE who has. So now, knowing the biopsy, you want to kind of regroup her in some syndrome. You have the biopsy, you have the kidney function, you have proteinuria. Tell me how much is the proteinuria at this point?
Ma'am, at the time of current presentation.
Admission to you.
Yes, ma'am. In routine it was 3+, and in UPCR it was 10.24.
Okay, 10 grams of proteinuria, a creatinine of 2, and you also have the biopsy by now. Now you want to change your syndromic diagnosis?
No, ma'am, I would keep it as nephrotic syndrome.
Nephrotic syndrome. Or maybe RPGN? You want to call her RPGN?
Not usually RPGN has a normal blood pressure and more.
RPGN doesn't have normal blood pressure. ये किसने कहा है? RPGN blood pressure doesn't come in the way.
There is no oliguria, there is no anuria. So
no, but look, what you have is a high creatinine, a low GFR. Subsequently, you have huge proteinuria. So it's a glomerular disease which has rapidly progressed. There's no chronicity in the biopsy.
Biopsy had chronicity.
Is all. Kahan hai chronicity?
Only 2 out of 12, which was quite.
Huh? Just say that again.
2 out of 12, ma'am, the chronicity score. So it is low score.
No. Don't read the scores. You have given me a description of 10% IFTA and 24 gloms non-sclerosed. So, in my understanding, there is no chronicity. Forget the scores. Look, you should always read the detailed description rather than just the last line. So, according to detailed description, there is no chronicity. 10% IFTA will not be called significant. Okay. No sclerosed gloms, no secondary FSGS also. Right? So there's no chronicity. It's all activity. So you could call her RPGN, according to me. All right, just a thought. Okay, now how will you manage her? So let's go back to September now, 22. She was given steroid. Was that a good idea, bad idea? What was it?
I think it was a justified thing to do.
Okay.
She was in active disease and the back she had shown a...
Okay, let me rephrase my question. Was she sufficiently treated or inadequately treated?
That we're not very sure enough, because from the documents, the prior medical documents, it was clear that she had received steroid. Whether pulse was given and then she was turned to oral steroid, not sure. There was no history.
Let's assume you do not know the doses. Or let me tell you, she was given pulse steroids. For a second, assume that. Yes. Then will that make it sufficient treatment?
No, ma'am.
Why not?
She should have received, another immunosuppressant, because such active disease class 4 would, for initiation, would require at least 2 immunosuppressant.
What other immunosuppressant are you talking about?
We have the options of cyclophosphamide or mycophenolate mofetil.
Okay, tell me one thing. Which study, or let me make it more clear. So steroids alone versus steroids plus another drug. So which study kind of conveyed this to the nephrologists? That steroids alone are not good. We are not even talking about the severity of disease. Let's say this biopsy was just a diffuse proliferative.
That was the initial
Forget
study.
crescents, forget everything. Okay, then?
That was the NIH study.
Okay, so what did NIH tell you?
NIH showed that IV methylprednisolone with short course of cyclophosphamide or higher dose cyclophosphamide was better than only steroid plus.
Okay, so this is what I wanted you to derive at. Steroids alone are not a good idea. So this treatment was grossly inadequate. Okay, and the worst part about this is she was anyway severe disease. Let's say somebody with milder disease, class 4, but not so crescentic, not so much necrosis. You treat them with steroids, they will initially get all right. Okay, but what did NIH tell you? When does the separation happen? When do you come to know that steroids alone are not good? Those who received the second line did better. So how much time does that take?
I don't remember the exact duration, but it was weeks, because the steroid, once
we taper years.
Once we taper off,
the curves started separating 3-4 years later. All right, and at the end of some 8-10 years, there was a stark difference. Those who received cyclophosphamide did well. Those who received steroids alone went into ESRD. Okay, so steroids alone is never a good idea. Okay, so that's the message learned here from this little girl. Okay, one thing more. How does childhood lupus, I am calling her a child, so how does childhood lupus differ from adult lupus? Vis-a-vis, let's say somebody who's 35 versus 15, 16. I'm digressing a little, I'll come back to treatment. Yes. There are differences in childhood versus adult. I remember basically one difference. And
adult lupus can often, not often, but sometimes can present as nephrotic syndrome rather than an active disease. Not seen in.
Remember just one thing. Childhood lupus is always more severe than adult lupus. Okay, childhood is bad. Childhood lupus leads to so much pulmonary hypertension. It's a bad disease. So relatively, if you were to take 100 children versus 100 adults, childhood is much more severe. And you need to be more aggressive. Children have better immunity. When you so this is an autoimmune disorder. Remember it this way. So they have more immunoreactive system, let's say. So autoimmune disease is more severe. It's as simple as that. Even when you take them for transplant, you put them on high risk children just because they have stronger immune system. All right, it's a much more severe disease. Okay, so you need to be much more aggressive about it. Okay, so now that she has come to you and 6 months down the road, what did you do? So this was at admission, right? That 10-gram proteinuria, the biopsy is 6 months old, and her creatinine is 2. Right?
Creatinine was 2 back then, ma'am. The current creatinine
2
was
back then. So when she came to you, what was the creatinine?
3.84.
3.8. Okay, so 3.8, 10 gram proteinuria, 6 months of sickness, right? Am I right?
Yes.
And to begin with, a bad disease, which
Yes.
50% crescents?
Ma'am,
No,
yes.
10 out of 24. Okay,
40%.
35%, let's say. Fair number of crescents. Okay, now what, and partially treated with steroids. How will you approach her now?
Keeping just looking at the disease course, as you told,
Mhm.
it is a pretty aggressive disease. So I would
Right.
give her a low dose cyclophosphamide, taking into
So
account
you
her.
will give her a low dose cyclophosphamide.
Will reduce the dose because creatine is GFR is also low.
Okay.
So we'll give her some pulse cyclophosphamide, and we'll again give methylprednisolone pulse, and then
Mhm.
oral steroid.
All right. Uh, any other thoughts? Anyone has, any of the audience has any other thought on this? You remember she's 6 months down the road with a
Yes,
severe
ma'am.
disease.
Yes.
If I argue with you that this girl already has a fried kidney, then what? Is it possible?
Ma'am, could be, but that can only be proven with a repeat kidney biopsy.
Who's stopping you to do it? So a girl who's 6 months into the course with an initial very bad biopsy. I would call this a very bad biopsy, right? So she and her creatinine, despite steroids, has risen from 2 to 3.8. 4 is considered unless really, so this is no longer just acute.
So
This has been going on,
yes,
correct? 2 to 3, if she had to respond to steroid alone, she would have responded.
right.
Okay. So in your mind, you have to find why her creatinine has increased. Look, for initial response, steroids are responsible. Just now I told you the NIH phenomena. The curves separated much later. So the initial response comes with steroids. A long-term benefit will come from other immunosuppressants. Agreed? So now I would say, and what did urine route and it's, how much hematuria did you say?
Ma'am, I did not tell. 4 to 6 RBCs, but there are no casts.
Okay, so 4 to 6 RBCs and no casts. All right, you have made my point even stronger now. Okay, so let's say you have treated a lupus 6 months down the road, whether sufficient, insufficient, whatever. Okay, so as this patient recovers, what happens to urinary findings?
The protein should have decreased, and
One is protein should have decreased. Okay.
RBCs should have disappeared or maybe
Okay, so
increased.
the so-called activity from urine, which is RBCs, have disappeared. There are no costs.
No cast.
Okay. Now somebody was treated, forget inadequate, adequate. Let's say this girl got adequate treatment, मान लिया, for a minute, let's assume so. Then 6 months down the road, she is on adequate treatment. Her creatinine has increased. Her RBCs have vanished. She persists with gross proteinuria. Now, what do you think she has?
She could be in stage maybe 4 and 5 combined, or maybe 5. I mean, she's progressing to chronic kidney disease.
That's what you should think, that she is sclerosing her kidney. So at this point, with these numbers, 6 months down the road, somebody with a 4 creatinine, 10 grams proteinuria, no RBCs, no casts, I would say her disease activity has fried her kidneys. And you should have done a repeat biopsy. I'm not blaming you. I'm trying to teach you what you would do once when you get such a girl again. Okay, no aspersions on anybody, but this is how I would treat this girl. Rather than blasting her with more immunosuppression blindly. Get my point?
Yes, ma'am. I get it.
So, anybody, when you start treating, and you also estimate extrarenal activity. So, did you repeat a anti-DS DNA?
Ma'am,
Was it lower, higher?
it was high, ma'am, but not as high as the earlier one.
So, dsDNA had come down,
Yes, ma'am.
correct?
Yes, ma'am.
Okay. dsDNA had come down. C3, C4?
It was low this time also.
Lower than last time or less low?
All, nearly similar, ma'am. The last time it was very
Nearly
low.
similar.
Nearly
Okay.
similar.
No. So, I think the learning point here is to be liberal on repeat biopsies. Okay. SLE is always a changing game, right? But kidney function has deteriorated so much that it's very likely that this girl's kidneys are already fried. All right. So the biopsy is the only thing which can tell you how much is activity, how much is chronicity. And let's say you do a repeat biopsy, okay, and you find no disease activity, and this kidney is half sclerosed, then what would you do?
I would like to keep her on
Would you
immunosuppressive.
have, let's say, if you had done a biopsy, it showed a high chronicity index in your parlance, or let's say now out of 24, you find 20 gloms now, 15 are sclerosed, what would you do?
Supportive management, ma'am. I would have
All right.
kept her on supportive
Okay.
management.
All right. Also, in such a patient, you would look at extrarenal as well. If she still has some activity, you need to treat at least her extrarenal lupus. Correct? So you may give her some immunosuppression to deal with extrarenal lupus, but this kidney is not going to come back once 15 out of 20 are sclerosed. That's what you need to think about. Okay. So where else do we go from here? You gave her methylpred pulses. How much?
Ma'am, 500 milligram.
500 multiplied by
3 days, 3 doses.
3 days. How much oral will you give her after this?
I would like to keep for 40 milligram to begin with.
Okay. So, okay. At what? 0.5 milligram per kg? 1 milligram per kg?
Minimum, weight was around 55, 48.
Okay. So, this is roughly 1 milligram per kg. All right. And how much cyclophosphamide? Did you have any other choice besides cyclophosphamide here? Why
Yes,
did
ma'am.
you choose cyclophosphamide?
Ma'am, Ritux would have been another choice, Rituximab.
Ritux would have been other choice. So usually at first line
MMF
SLE
also.
treatment, so you just now said MMF. So
Okay.
why did you choose cyclophosphamide over MMF in her?
Ma'am,
How do you make that choice?
ma'am, I thought the disease activity, the disease was quite progressive and active. So we should use a drug which is more first line than rituximab. Rituximab
What
was
did you discuss with her or her parents before giving her cyclophosphamide?
that cyclophosphamide in a young girl like her would probably there is chances of conception in the down the line. So there would be some gonadal toxicity as well.
Some or huge?
That would depend on the cumulative dose. If we can keep it below maybe 10 grams, so
So
we
how
expect
much cumulative dose would you allow her?
The cutoff would be 10 gram. I'd like to keep it below 10. So if I give
So
6
is
to
the gonadal toxicity different at different ages? Is it different in someone who has renal failure and does not have renal failure? Renal failure as such is like bad state for the ovaries. So I don't know, the chances are the gonadal toxicity becomes higher with a GFR of 20. That's what I would imagine. I'm not sure about it. Anybody wants to contribute to this knowledge or guess? Okay, subject to checking. I'll check it.
if the GFR is less than 30, we reduce the oral dose by 2.5.
Any dose. Okay, initial. So how much did you give her?
25%
What is low dose cyclophosphamide?
500
What?
milligram.
500 milligram?
Once in 2 weeks.
Okay, every 2 weeks. So which trial has used this regime now?
This was Euro lupus.
Okay, Eurolupus. Okay. So now tell me another trial which has done cyclophosphamide versus mycophenolate.
That was arms trial.
That's ARMS trial. So what's the basic difference between ARMS and Eurolupus? Or just tell me briefly, what were these two trials about? Because largely we are discussing treatment today.
Arms trial looked at MMF versus IV cyclophosphamide. It was shown that MMF was non-inferior.
So what kind of dose of cyclophosphamide did they use? That's important to know.
They had used the lower dose only. Induction.
ARMS used the NIH dose. So what was NIH dose now? They use the NIH dose. Let me tell you that. Okay, so that dose used to be?
1 gram monthly for 6 months.
Not exactly 1 gram. It varied between 0.5 to 1 gram. Every month, I think every 3 weeks or something like that, NIH dose for the first 6 months. And then every 3 months or so, something like that was the dose. I hate cyclophosphamide. So anyway, so it used a higher dose actually versus MMF. And what was the dose of MMF used?
That was 2 to 3 gram for.
Okay, good. So that was 2 to 3 grams. You begin with a small dose, go up, try to go up to 3 grams. Okay. And even then MMF was non-inferior to cyclophosphamide as initial therapy. Eurolupus used 500 mg every 2 weeks for
3 doses.
3 doses नहीं 3 months था शायद 3 months होगा 2-3 doses नहीं हो सकता. It has to be 3 months or maybe 24 weeks. 6 months. 6 months. This was 6 months. Okay, but the dose was fixed at 500. All right. So that's where, and so what was the other major difference between Eurolupus and ARMS trial in terms of demographics? I'm giving you a hint also. Where was Eurolupus conducted?
This was mostly Caucasian population.
Well, okay, so Eurolupus was largely white population. Okay, and whites are the fortunate ones. Any disease is mild in them. So where is lupus bad? In blacks and Afro-Americans. Africans, let's call them Africans for now, whether living in America or Africa. So lupus is a much worse disease in them. It may somewhere Asians may be in between. And Eurolupus was a white population. So it's a milder disease. So low dose may be as good. That's the argument against that study. Okay, that they were all white, they would get treated with a mild dose also. All right. So in AMS, there was a fair representation of Africans. There was a fair representation of Asians. All right. So that was the main difference. Any new trials that you are aware of? Any new drugs that you are aware of in lupus?
Ma'am, there was Bliss LN trial, ma'am. That
Bliss what?
Bliss Allen, ma'am, for belly mover.
Bliss Ellen, lupus nephritis. Okay, what is Bliss trial now?
Ma'am, belly mover can be used as a add-on therapy to either steroid plus MMF or steroid plus cyclophosphamide.
Okay.
When those two are not being enough to contain the disease activity.
Mhm.
Then there was an Aurora trial
Okay,
for
let's hold on. Why was it called Bliss? Why was the trial named Bliss?
because this belimumab acts again this B cell ligand activating factor.
Okay, so what is Bliss? Do you know what is Bliss?
Um, uh, Full form I don't remember.
Full form nahi hai. Somebody calls it BLYS, somebody calls it BAF. But
B
what
cell
is it?
activity.
Somewhere in the. So, what is it? It's something to think about. April study, something called April, something called Bliss. What are these two things?
These are
Both cytokines somewhere.
yes.
Okay, produced by, I think, B cells. So it's indirectly blocking those cytokines produced by B cells. Or they stimulate B cells. That's what somebody is telling me. Okay, it has something to do with B lymphocytes and these two cytokines being made by them. And no, it doesn't stop the B cells from making it. It stops the cytokines from acting somewhere on some receptor. I can't remember where. But these two cytokines, so there is April, there is Bliss. Have you heard of an animal model of lupus? Am I asking you too much?
No, no.
Okay. So that animal model of lupus is some Bliss transgenic mice. And they get a host of autoimmune diseases, including lupus nephritis. Okay. So Bliss has something to do with a lot of autoimmunity. Okay. So read about the animal model also of lupus. It's the understanding gets better. Okay. Now we can come to Aurora. What's Aurora?
Ma'am, the voclosporin was looked into. So
Okay.
it was seen that voclosporin can be a again choice of therapy if added to steroid, particularly when a patient is unable to tolerate MMF in full doses or has
Okay.
or we cannot use cyclophosphamide. So
Okay, tell me one more thing. When you start therapy in any lupus, steroid plus MMF, how many of them would you think would respond very well or attain a full remission?
30-40%.
30 to 40%. So there would be some left who have not achieved a great remission. And that's where all these add-on therapies have a role. So if I remember correctly again, the population in Aurora, the population in Bliss was somewhere, how many years post-diagnosis of lupus and post-treatment? So they were all, I think, roughly three to 4 years. 3 to 4 years they had been treated with either MMF steroids or cyclophosphamide steroids, but still had the entry criterion, some proteinuria, whatever it was in either of them, right? So significant proteinuria to put them as active lupus nephritis. Okay, though there were no biopsies to say how much is chronicity, how much is activity. The biopsies were, I think, somewhere in previous 6 months, I think, something like that. So what does voclosporin do? Why not give them regular cyclosporin?
Ma'am, the advantage with voclosporin is that it has a larger therapeutic window, I mean index. So we don't have to monitor the serum level as frequently as we do, or we may even completely do away with it.
Yeah,
And
that's what I thought. No one does levels of this drug.
Yes, ma'am.
Uh,
Cyclosporin or tacrolimus we keep up to um, looking at. Also, the side effect profile was a little, better than it was much better
okay, so
tolerated than
it's a
other.
designer cyclosporin, as I tend to call these things. All right. So how much was the benefit? If this became available, will you start it?
I'd still stick with
Would you give it to this girl? Okay, let's come back to the girl.
no, ma'am, not at that point of time. Even if
Even
there is,
if it was around and freely available, why not?
ma'am, this would only be used if the patient is unable to tolerate the first line medications.
That's
So
a
I
wrong
think
thought. That's not a good thought. So the key to adding a third drug or a third therapy would be an inadequate or a partial response to the first drugs, which may be because of intolerance, which may be because of whatever. I mean, somebody who's receiving 2 grams of mycophenolate or maybe 2.5 and has received adequate steroids needs add-on therapy. It's not necessary that that person is intolerant to MMF, right? So you add a therapy. So that was the philosophy behind the multi-target study.
targeted thing. Yes,
You do the same thing in immunosuppression. You block various pathways, right? So it's incidentally, the doses were low because some patients did not tolerate it. It's one of the reasons. Or somebody may have been non-compliant, somebody left therapy, somebody took half the dose for various reasons. Okay, it was just one factor. So how does how could, let's say, a CNI reduce proteinuria in such a girl,
ma'am,
or any SLE or any disease for that matter? What does it do? Anyone? One is immunosuppression, but two, you should know something else also. What does it do? You give it to all nephrotics, right?
they change the this renal hemodynamic parameters.
What hemodynamic parameters? It will worsen hypertension. What else does it do? It does something to the glomerulus or something in the glomerulus. It stabilizes the cytoskeleton of podocytes. So it has a non-specific effect on reducing proteinuria. It may be any disease, but again, coming back to this girl, let's say you have an SLE patient who has a creatinine of 2.5. You think a third drug needs to be added. Would you add a CNI?
At the current presentation, when
No,
the
forget this girl. Anybody with SLE or has a creatinine of 2.5, will you add a CNI?
yes, ma'am. If the disease activity is so high, we'd like to add. Although it can have its own
Okay,
nephrotoxicity.
so one principle you should remember about native kidney disease and CNIs, you don't add a CNI if the GFR is already low, because CNIs are going to destroy it further. CNIs are nephrotoxic, you know that.
Yes,
They
ma'am.
cause vasoconstriction, hemodynamic effects. It's going to further deteriorate the GFR. So any native disease, whether it's SLE, whether it's membranous, whether it's anything, if there is significant impairment of GFR, I don't know where to draw a line, but I would draw it at a much higher. 2.5 creatinine gives you a GFR of, let's say, not more than 25, at least in Indian population. Okay. So always remember that. It's never a good idea. Okay. You find another drug to add. Bliss, if it was available, would be a good addition, right? So you add something else. Rituximab would be a good option if you had to add on a therapy here, right? So where do you use rituximab in lupus?
Ma'am, rituximab can be used if again as a add-on therapy, or if we think that the patient is unable to tolerate any of the first-line drugs, or also in refractory lupus.
So you put the first indication at the end. So somebody who hasn't responded to your first regime, which may be cyclophosphamide, which may be MMF. So if MMF doesn't work, you add you give cyclophosphamide. Or if cyclophosphamide doesn't work, maybe MMF, or you give them rituximab. So resistant disease, as it is called. Okay, anything else? I think that's all I could talk about treatment. But you should have biopsied this girl. She has left follow-up, otherwise you would know her follow-up.
She expired, ma'am. She passed away.
She passed away. Okay, so what happened to her? She left you. All these patients who expire should teach us a lesson. Okay. So what did she die of?
She had presumably lower respiratory tract infection. She had LRTI, and the kidney function deteriorated. Family did
So
not
she
agree.
got a pneumonia. All right.
She had a Press syndrome, and she was intubated. Family did not consent for hemodialysis, and then she passed away. This was in at another center.
At another center. No, so the point I'm trying to make again is patients whose kidney is not going to recover, right? Things like cyclophosphamide, things like tons of steroids are going to kill them. Rather than treat the disease, you end up killing the patient. Okay. So one should always kind of look at disease activity versus a kidney. 6 months with that kind of a biopsy, inadequate treatment, either she would respond or her kidney would be sclerosed. 6 months is enough to sclerose the kidney after such a biopsy, I would say. Definitely. Okay. So no point immunosuppressing them further. Do a biopsy. Be objective whether to treat or not to treat. All right. Anyone else out of, I know some familiar names who are my candidates. Dheeraj, Sunil. You guys have any? Ankit, any questions? Anything more could we add to this? Ma'am, my criteria to repeat biopsy. Who was this? I didn't get the full thing. Why don't you join in and say it loudly? Who was this? Chat box. One second, let me get it. Oh, there are lots of messages in the chat box. All right. Okay, let me address these questions now. Okay. I'll just read out the whole thing. Today, names. Okay, 20% false positive in normal people. So with a titer of 1 in 80, it comes down, I believe. Okay, Reshmi Das says 5. What is this 5, Reshmi?
This was the
Okay,
one
5%, 5%, in contrast to 20%. Got it. Okay, Mitesh says 30% positive. We have talked about it. Something is more specific. Mitesh Makwana, what did you mean by more specific? Most specific? Mitesh may have left. Okay, something PS, I don't know. Coombs test, Dheeraj, fine, retic count, LDH, hemolytic anemia, DCT, autoimmune hemolytic anemia, DCT again, TMA, factor H antibody, so that's part of TTP. Oh, sorry, C3 hemolytic syndrome. APLA, we talked about this. NIH, Reshmi, good. Childhood is more severe. That we should always remember. Childhood is more severe, gonadal toxicity. So our first choice in this girl would have been MMF, but yeah, Bliss, B lymphocyte stimulator, belimumab. This spelling needs a little correction. Lumab नहीं है, ये mubab है. B lymphocytes stimulating, less adverse effects. I bet this is MMF. Hemodynamic effects, vasoconstriction, podocyte protective action. So podocyte remodeling. So this is what is cytoskeleton stabilization. Podocyte stabilization, same thing, good, Dr. Deep. In normal GFR, so this is, I think, 7:40 p.m. My answer. Who do you give CNI in normal GFR, then can be given. So that was the stress I was laying. The GFR needs to be near normal. Resistant lupus. Okay, ma'am, any criteria to repeat biopsy in lupus? Okay, Darshit, you want to come alive? When will one consider stopping therapy in lupus? Role of plex. Okay. So, okay, any criteria for repeating biopsy in lupus? Anybody wants to, Ankur, you want to say something about it?
If we expect that disease has changed the stage, which can be caused by if there's any increase in the proteinuria, uh, I mean, significant increase, like there's a jump of more than a gram, or there is again there are active sediments now which were not present earlier. So
Okay.
all these things.
So whenever you expect, I think, a flare, like this girl was a perfect fit into repeating a biopsy, for example. She had increased creatinine, she had increased proteinuria. So she was a perfect fit. And anyone, let's say, so it's a known phenomena that assessment of disease activity by peripheral means is very different from a repeat biopsy. Okay. So some people go to the extent of saying you are treating an SLE, everything is hunky dory. The woman seems to be responding, the patient seems to be responding, everything you think is fine. Even then, if you were to do a protocol biopsy, you may find activity which could modulate your immunosuppression. Okay. And definitely, if you are suspecting a flare, a fallen GFR, increase in proteinuria, a new sediment, definitely you should try to repeat a biopsy. Okay, so according to me, one should lean towards repeating a biopsy than not repeating a biopsy. And especially type 4, type 5, many a times you may have added class 3 and 4, which changes your treatment. Okay. When will one consider stopping therapy in lupus nephritis? That's a very tough question to answer. So if you actually go back to data that after stopping, how many would actually come back with lupus? I think the percentage is somewhere around 30-40%. Okay, so but most people will say, okay, if you have treated it maybe 2 years, 3 years, if there is no activity, you stop it. And many a times you kind of reduce the dose of mycophenolate, which is the most commonly used drug, as maintenance as of today, or it would be azathioprine. So you gradually cut it down 1 year, 2 year, 3 year, and then try stopping it and monitor them for disease activity. Okay, but many times I've seen these, the rheumatologists actually stop it after a couple of years. And I remember having done a fair number of biopsies for rheumatology people, at least at Apollo Hospital, because the time they stopped it, 3, 4, 5 months, they come back. I actually prefer to kind of let them continue on MMF in a low dose, something like 1 gram a day. So I would make it 500 twice a day and let them be on it. So there is no clear-cut guideline on it. Okay. So, and role of plex. Role of plex is actually, where would it be? I think patients who have a combined vasculitis or lung hemorrhage, or maybe antiphospholipid syndrome. I am not sure about this answer. Feel free
TMA.
to check it. Anyone wants to contribute when to plex these people?
If Mostly Plex roles comes in TMA with if as you
Exactly,
told,
TMA. So
DNB
that's
Class
where I think we used to
series.
flex them. But now that, look, that was mentioned some 15 years ago. I also grew up thinking any TMA and SLE, you flex them. But now I think what we need to do is TMA is because of three reasons: TTP, C3,
Yes.
C3 modulated or mediated TMA, or APLA. You kind of address the cause, whatever specific it may be, out of these three. And the treatment for the three is different, right? For TTP, it's ADAM-TS, so you could do plasma exchange and give FFPs. For the second one, it's eculizumab. For the third one is treating APLA. Put them on anticoagulation and treat lupus at the same time. Okay. So now you address the cause of TMA. So that I think has changed in these many years. Initial literature said any TMA, you plex them. That's what I would kind of read in between the lines. Not that I've read it specifically. Okay, 3 new messages. Let me see those also. Biopsy before stopping immunosuppressives. I don't know. It's one of those very tough decisions. So, not really. Biopsy before stopping immunosuppressives. There may be advocates of this, those who do protocol biopsies, but most centers do not do it. If there's no disease activity anywhere, they stop immunosuppression. As I said, 2-3 years. Low dose may be continued, but I have stopped some after 3 years and they are doing all right. So, but definitely if something new comes up, I would definitely rebiopsy them. All right. And lastly, some patients may have anti-dsDNA values which remain positive, or at times they may be fairly highly positive. Okay, so let's say 1 year down the road, you find a DNA of 500. What do you do? What would you do? Anybody wants to comment?
High DNA level has no prognostic effect. It only shows that the disease activity is high, so we'll have to treat the patient with probably immunosuppressant agent.
So I didn't get it. So you would treat this person or not treat him?
Ma'am, if I'm not doing a biopsy, then I treat.
So no. So somebody who's on treatment still persists with DNA antibodies and everything else is good, extrarenal, renal, or whatever is good, you don't hike your treatment looking at dsDNA alone. Okay. Complement is more difficult. If it's accompanied with a low complement, that's a better sign of activity than just dsDNA, a persisting high dsDNA, or varying dsDNA. So most people would say do not address it, just leave it alone and monitor them closely for clinical activity. If clinical activity comes back in whatever format, then definitely. Lastly, HCQS. I don't use it. So what's your take on HCQS? And then after that, we can close.
Ma'am, KDIGO guidelines say that SCQs should be given until and unless there are absolute contraindications like the
Yeah,
eye.
that's what it is. So most rheumatologists, and they make all the criteria, right? For lupus. They say everyone, unless there is a contraindication, should be on HCQS. A lot of nephrologists do not use it, but I have a feeling now, the more you hear from rheumatologists, I also don't use it. So we should be using it, everyone. So this is on the side. Okay. All right. Anything else? Anyone? And otherwise, we can call this a close. We are close to 8
Ma'am,
o'clock. Anji?
regarding stopping, this is Dr. Gauri Shankar.
Yeah, go
Regarding
ahead.
stopping of therapy, even though we don't have any guidelines, there's one study, which is WIN-LN study. where they have prospectively segregated those people after around 2 years of remission induction and maintenance. They have done prospective biopsies. And in the
Okay.
biopsies, based on the activity index score, if it is more than or equal to 1, in those, after stoppage of therapy, they found that the chance of relapse was so high compared to those who had an activity index of less than or equal to 1. So that can be taken as one of
That can
the
be taken as a
things we
guide.
can.
That I agree. So this is said about lupus, na? So the problem is those, as I said, so patients who are clinically good, we think they are in a remission, but the biopsy may say otherwise, right? So ideally, lupus patients should have protocol biopsies throughout, the course of disease.
Yes, ma'am. And
They should have
one more
maybe every 6
indication.
months, 1 year, they should have protocol biopsies. Nobody
And
does
one
that.
more indication. Yes, ma'am. Absolutely, ma'am. And
Yeah,
one
it's
more
not
indication.
pragmatic. That's the problem.
One more indication which I think regarding biopsy is when one is considering a change of therapy, when one is thinking that, say, for example, on MMF induction wants to add MTT after some 2 or 3 years, persisting proteinuria, to look at the chronicity index, because we were talking about infections. Most of the times in India, it is rather than SLE with disease activity, we land up with infections which is killing the patients. So
I
in that way, we
entirely,
can be medically and medico-legally correct.
I entirely agree. I entirely agree with that. So, yeah, in India, we overtreat them. We overtreat kidneys which are not going to recover. So, yeah, I entirely agree. So that's where it could help. But again, the same problem. Biopsy is such a it's very hard to convince patients. And first of all, we need to get convinced ourselves that we should be doing it. Okay, so once we are convinced, maybe, yeah. And difficult to convince patients to get repeat biopsies done. But biopsy is the way to go. Okay. Okay, then, bye-bye. Anything? Thank you, Ankur.
Thank you.
But, yeah. Hanji,
Thank you so much, ma'am. Thank you. Thank you so much, ma'am. Thank you for coming, and many, many birthday wishes in advance.
Okay, thank you.
Thank you. Have a nice day tomorrow. Thank you, ma'am.
All right. Thank you, Puneet. Thank you, Ankur. Bye-bye.
Bye.